Welcome to Operative IQ's Wisdom Webinar Series. We hope the information and experience shared by our speaker today will help you improve processes and take your organization to the next level. I'm Lisa Rainey, Director of Business Development, and our team is so pleased to be able to provide you with some great narcotics tracking information. Today's presentation will outline steps you can take to minimize narcotics diversion and protect your organization and your providers. Before we begin the webinar, we have a few housekeeping tips to help you get the most out of your time with us. All lines are muted to reduce noise feedback, but we'd love for you to use the question feature in your GoToWebinar control panel to submit your questions as they arise. After the presentation, we'll have time for Q&A, where we'll address as many of your questions as possible. A recording of today's webinar will be emailed to all participants, and we'd love to hear your thoughts and feedback. So please complete the brief survey at the end of the webinar. We're so excited to share some great information with you today and introduce you to your presenter, Shaun Curtis, who manages the narcotics program, among many other things, as the support services manager for MedStar Mobile Healthcare. Shaun will share with you some of the issues that they faced and steps that they've taken in an ongoing effort to increase efficiency and quality. MedStar Mobile Healthcare in Fort Worth, Texas has been an Operative IQ user since April of 2015. And Shaun has previously served as a field paramedic and then in risk management prior to taking on his current role about 3.5 years ago. Shaun will reference some resources in his presentation that have also been added as handouts to this webinar for easy access. And with that, it is now my pleasure to turn you over to Shaun Curtis.
Well, thank you so much, Lisa. Like she said, thank you for joining us today. My name is Shaun Curtis. Share with you a little bit about me here in just a moment. I'm excited to share with you guys our journey through narcotic management. We started with these sort of vague paper trails in the beginning and are up to real-time vial by vial tracking. So happy to share that with you. And I always enjoy sharing these things because it gives outside eyes an opportunity to dig through our processes and our protocols to hopefully find something that will help them, but also an opportunity for you to look at how we're doing things and maybe find ways that we can improve. Because a successful narcotic management program is the core of it is in constant evolution and process improvement. So first and foremost, who the heck am I? Like Lisa said, my name is Shaun Curtis. I'm currently the support services manager. I've been a paramedic for just over 20 years. 19 of those have been here at MedStar. Worked as a medic, as the operations supervisor, risk manager. I'm currently also the CAS coordinator, and my title is support services manager, which oversees the fleet department, logistics, and facility maintenance. So second question, who the heck is MedStar and why does that matter? Shaun, the ringleader there. MedStar Mobile Healthcare is a public utility model that works for 15 different cities. It's much like the water department or airport. We're not a private entity. We're not associated with other MedStars across the country. We are just MedStar of Fort Worth and the surrounding cities. We cover 15 cities, about 437 square miles. Last year ran 158,000 calls and transported about 2/3 of those. So since we're talking about narcotics, some fun facts about the number of narcotics that we sort of manage here at MedStar. On a daily basis, we pass about 1,300 vials of narcotics through our logistics window. And when I talk about the window, and I'll mention it several times this afternoon, this picture sort of gives you what our logistics window is, if you will. It's a counter. It's where all of our assets and narcotics are assigned at the start and then checked back in at the end of every shift. We go through about 9,300 vials a week, which gives us a total of about 500,000 vials going back and forth over this counter every year. And what we're really proud of is in the last 12 months, we had 15 narcotic anomalies, and I'll explain what that means later. They're basically errors in the protocol or process, which gives us a failure rate of 0.003%. So one, really excited that we can share that, but two, that we can even track that, and we'll get into how we do that later on. So like I talked about, our narcotic management journey started in paper, like many people do, and it was what I was familiar with when I came to MedStar. There was a manual process for documenting the transaction, so that is the narcotics going from logistics to the paramedic and then back and forth every day. There was another paper that documented usage and waste. The paramedic had to indicate how much they used, on what run number, how much they wasted, and then reliably get a witness signature that was or wasn't, legible from who knows where they got it from. And then the process for going back to do audits and documenting usage or trying to track errors just took hours. It was a very manual process of going through stacks of papers, hoping that those papers hadn't been lost, and then when you found them, hoping that they were legible enough to get any sort of usable information out of. So lots of challenges, lots of opportunities for errors, and very little opportunity for the recognition of diversion. If somebody was diverting, it would be very, very difficult to capture with the paper management process. So we evolved, right? Everybody wants to evolve, get better, so that's where we started. We started with a SharePoint list for documenting the transactions, at least. So now I had an electronic repository that showed who was getting what drugs, how many were going out each day, and basically that they were coming in and out, but that's sort of where it stopped. I couldn't check to see who had what vial numbers. I wasn't able to identify individual usage unless we really dug deep into the manual papers again. So although I had started on this electronic management, we hadn't gotten very far in. And while SharePoint is useful in that I can export and sort through Excel files and sort of dig into information, it was still pretty vague information that didn't give me enough detail to help me manage the process very well. So in 2015, we finally transformed to a fully electronic process. That is, all of our transactions with narcotics are captured within our EPCR software. That's ImageTrend. We're using ImageTrend Elite currently. And then all the narcotic usage, waste, and the check-in, check-out process is tracked through Operative IQ, which also requires a witness signature for all usage, and that's all captured electronically. And then audit data is pulled from both the EPCR and the Operative IQ database to analyze, one, to make sure there's no errors, and we'll talk more about that here in a moment, but also to check for diversion, overuse, underuse, any of those sorts of things that may be clinically significant or may point to a possible anomaly. And we'll dig into that here in just a few. So we use the tags. This is one of my favorite parts of the OIQ system, is that each tag is color-coded. Each vial is uniquely ID'd, and on those tags, they have the lot and the expirations. So as we're moving these things back and forth, it allows us to check for expirations very quickly. The expirations are highlighted in the system as bright red, so it makes it very user-friendly. But also, as many of you probably experienced, fentanyl, ketamine, some of those things are difficult to get, and so the vials change often. And so to help mitigate medication errors, because now my fentanyl looks a lot like my Versed, but you can see, here in this picture, the fentanyl is on the bottom left, the Versed in the middle there behind the Dippervan. Both of those have a green lid. So looking at it from the top, I've got two vials with a green lid. It makes it really easy to make an error. Fortunately, the vial number or the vial tags are color coded, and so I always know that if I grab a green tag, I'm grabbing fentanyl. If I grab a yellow tag, I'm grabbing Versed, and so on. And if they do have the same vial color, so you can see the vial with the red top, that's succinylcholine, and then the ketamine, both have a gray label. They're kept in separate containers to further separate those to mitigate any medication errors. So very helpful there. And then we also consistently package all the narcotics. This is a Pelican 1010 case, really easy to get from, you can get it from Pelican Direct or from Boundary or from anybody. But we were able to pre-fill these narcotic pouches and assign narcotics to each pouch. So that way, when the paramedic comes in to check out drugs for his start of shift, he can very quickly and easily see that I've got 9 vials in here. I've got 4 of the yellows, 4 of the greens, 1 of the grays. And then as we reconcile the vial numbers that are assigned as to what's in the case and what's in Operative IQ, it's very quick and easy to see what's in there. So not only does that reduce our error rate, but it also makes for a quicker turnaround time. So I don't have paramedics standing around at the counter getting paid for unused FTEs. They're in checking things out and then getting back out onto the street, and also makes it much quicker to resupply when that's needed as well. We do use dual verification here. So when any narcotic goes out from the safe to a paramedic, it has to be signed off on by our logistics tech, that is the person checking out the narcotics, and by the paramedic, and the same thing coming back in. And in that way, there's some a good way to reconcile that, but there's also some accountability. So if there is an error, I can go back and talk to two people and say, hey, how did this happen? And so again, it reduces that opportunity for error when you have that accountability on both sides. So very helpful there. So some of the methods, and we'll dig into each one of these a little more. We train a lot. We have step-by-step SOPs, and I've shared a lot of those SOPs, like Lisa talked about, and those are available for you to dig through, pick apart, and use any, all, or none. We test on our SOPs every year. We've talked a little bit about the packaging, and then we'll talk some more about quality assurance here in just a moment. So the training that we use is anybody that handles narcotics, that is, they check them in and out of the window, or they receive them and utilize them in the field, have to understand our policies and our procedures before they can put hands on any of it. The training for our logistics techs that are counting and checking these things out and responsible for managing our day-to-day operation are given a little more training, and they have to score 90% on their test. And like I said, they are retested once a year to ensure they're compliant, they understand, and there are no challenges or drift in between those training opportunities. It's a competency-based training, so it's not just you have to watch this video and you're going to press play and then go do something else. It's a one-on-one, hands-on training at our window, at our logistics window that I showed you earlier, and then also it's a slideshow that they sit with a trainer and go through, and at the end have to complete the test, like I talked about, with a 90% pass rate. And then finally, we include HIPAA in that training because as my logistics techs are reviewing and reconciling the narcotic usage, they are getting a little bit into patient care records. So we want to make sure they are aware that that stuff is confidential and they can't share any piece of that. So just one more sort of reminder on the HIPAA thing as they're with the organization. So several policies and procedures. The procedures tell folks how to do things. I've shared all these procedures with you on the website there. But as you can see, so this one here is how narcotics are checked out. And there's a box that shows that, the logistics tech does this. And then there's another swim lane down below that shows the paramedic's role in that process as well. And each one of our procedures are outlined in this fashion so that you can just follow the line to see what do I do next. If I forget something, I've got a piece of paper that I can go back to and reference and stay current with our current policies and procedures. And just as a reminder, procedures tell folks how they do it. Policies tell them what they can and cannot do. And so that's how we teach those as well. So to break down, I was just showing you that process map, and it was very convoluted, and I hope you weren't trying to write everything down. But this is it written out, right? So when a paramedic comes to the window and tells the logistics tech, hey, I'm on shift, 50, the logistics tech will confirm that, yes, they are on shift 50, and yes, that starts in 30 minutes, and so they are authorized to receive this. The narcotics only go to the advanced provider on the truck, so they'll confirm that that person is assigned as the advanced or the primary on that truck. If there's ever two paramedics assigned to the truck, somebody is usually assigned the advanced role. However, once those narcotics are checked out to that paramedic, either medic can use them. They have to just document that whichever paramedic used them is the one that administered, and that's documented in that EPCR and in the operative IQ system. Once they're verified that they are the advanced medic and they're the ones responsible for the narcotics for that day, the pouch is given to the paramedic for inspection. So both the logistics tech and the paramedic inspect to make sure the cap is intact, the vial is full of fluid as it's supposed to be. The label hasn't been compromised up to and including, we can read the words on it, the expiration, the everything. And then it's been labeled with a unique control number, and then that control number matches what's in operative IQ. And then finally, both the logistics tech and the paramedic put in a password and a PIN number to verify that, yes, this is what moved across this counter. These are all intact, in good shape, and ready to go out for patient care. Then in the field, if anything is used, there's a two-part process for reconciliation. So first, in the patient care report, we document what was used, and obviously this is for the healthcare providers, but that also goes into a repository that we use as a backup to operative IQ. And operative IQ, then they log in, document that I used this file number and I used this much of it, and my partner or other appropriate personnel signed as a witness. And in both of those things, they match a response number, the administering provider, what narcotic it was, the dose, the waste, and then who signed as witness. And to kind of give you guys a visual there, this is what they see. So on the left, you've got the image trend patient care record, and then on the right, the operative IQ record. And what they're looking for is that the control numbers both match. So you can see on this one, the control number for fentanyl was F29552. That's the same number in both of these. The waste was 0 on both of these. The administration was 100 mics on both of these. So this is then reconciled and considered complete. And at the end of their shift, when the paramedic comes in, they can be resupplied because all of their numbers and their documentation matched up and was correct. To ensure that we manage the narcotics correctly and we don't lose any vials, nothing goes missing, broken, or unmanaged for too long, we do multiple daily audits. So at shift change, there is one tech that works at the window, the logistics window that I showed you earlier, and that person works that window for the duration of their shift. And we maintain that one person for the duration of their shift to minimize the number of hands managing the narcotics. So at shift change, both the offgoing personnel and the new oncoming personnel do account of how many narcotics are shown in operative IQ and how many narcotics are physically in my safe that I can put my hands on. And that's reconciled at the beginning and end of every shift. Then in the middle of every shift, my supervisor does a daily count as well. They call it their mid-shift count. Again, it's done to make sure all the narcotics that are supposed to be out are out and all the ones that are in, and nothing is expired. And it's at this point that anything that's been administered is moved into a destruction box, which is deeper into the OIQ process, but that's where that's captured as well. The reconciliation of previous day's usage is also done. That's where I just showed you the two documents that they're compared for vial numbers, usage, wastage, response numbers, all those sorts of things are all captured during those audits to make sure that's done correctly. And then there's a weekly hands-on audit with a representative of our medical director. So he sends down a representative that basically puts hands on every vial that's in the safe to ensure the caps are securely fastened, to make sure we do indeed have the numbers that we say we have, to make sure nothing's been tampered with, and everything is basically as the medical director signed off on. And then our compliance officer has the ability to do random audits at any time and takes advantage of that anytime there's been an anomaly or anytime something strange has happened. And we'll talk more about anomalies a little later. When we're doing these audits, the things we're looking at are the total number of vials that are in the field. So how many vials of each medication do I have in the field assigned to paramedics at this point? And then how many are not in the field? So that is, are they in what's called the manager safe? So that's the primary collection point for all narcotics. Or are they in one of 3 distribution safes? And all of the narcotics come to one primary safe, and then we have separate little areas that they are handed out so that no one safe has too much narcotics in it at any time. And this includes any waste due to damage or expiration, and stays in the safe until it is destroyed, and that has to be done, of course, with the reverse 222. And then there's a virtual count in OIQ, and what that does is that looks at how many total vials I should have, and it counts the outside of safe and inside of safe and puts that together. And then we deduct those two to get an actual physical count. And those things all must reconcile. And what that count looks like. So this is your weekly count here that we do with the medical director, and it takes all of the drugs that show to be administered in the system, because they still show to technically be in the system until you virtually destroy those. It takes all of the vials that are out of the safe, so that is how many of each are assigned to paramedics currently in the system, and then how many are in each one of the safes. And so then you can see in the green bar there, that is the physical number of vials of each medication that should be in the safe. And that's what they reconcile against, to say that I should have in this safe exactly 36 vials of fentanyl. And if it's one, off, then we begin an investigation. But since we do so many counts, the window for error becomes much smaller, and it becomes much easier to then track where an error occurred and fix that or reconcile that. Most of the errors caused here are this is a human process, so somebody types in the wrong number into one of the columns, and that causes an error. And as we go back through and double check this thing, that's almost always where the problem is. The daily reconciliation, this is what the supervisors are doing. So you can see in that top red bar, this is the number of administered vials. So these vials are no longer physically in the system. However, they're virtually in the system because that vial number still exists until it's virtually destroyed. So that bar deducts that number of vials out from the total count. And all of these things, like I said, are in the handouts. And if you have questions after, or if you have questions in a week and you decide you want to use any of this, my number and everything is on the contact information. So happy to walk you through any of this. This intimidated the heck out of me when I started doing it, and now it's a breeze and I love it. So really helpful tool. Now, all of that's how everything works in a perfect world, when we don't have any problems and nobody steps on a vial or wastes too much or anything, right? But we don't live in a perfect world. Errors will occur. And so we call these narcotic anomalies, and that's any occurrence that occurs outside of normal protocols. That is a broken vial, right? So somebody opens their pouch, they're going to administer some Versed to a seizure patient. Well, in all the excitement, they drop a vial and it breaks. That's a narcotic anomaly that we investigate and go through this anomaly process. Or the vial is taken outside of controlled system. And what that means is, the paramedic has run a long shift and they didn't remember to turn in their narcotic pouch. They head to the house, they start, getting ready to clean up and realize, oh, dang, I've still got this pouch in my pocket. That has to come back. That's an anomaly. Begins an investigation. The investigation is started with the logistics supervisor. They start this process. It engages the operations supervisor as well, and then it works through a logistics manager, investigations, or support services manager, and then our compliance officer finally wraps it up completely. The drug screen may include multiple parties. So in this investigation, the supervisors are going to collect statements from each one of the involved parties. So take the broken vial, for example. If a paramedic comes back at the end of the day and says, hey, on the seizure patient, dropped a Versed, it broke, it shattered, it's gone now. The supervisor is going to obtain a statement from the paramedic, but also the EMT that was on that call with him to basically testify to, yes, that's exactly what happened. He didn't store it in his pocket. He's trying to sneak out of here with this. We're going to review the audit points and look at that person's usage to make sure there's no unusual usage or attendance challenges or anything that might sort of raise a red flag. And then there's going to be a drug screen for at least the paramedic. If the anomaly involves anybody else, say a pouch is lost or a vial is lost or something along those lines, then it may include the paramedic and the EMT, or something happens in the window, maybe the paramedic and logistics tech, or maybe just the logistics tech. So dependent on the circumstances of the anomaly, but based on the investigation, will push people through different drug screens. And you can see it's a pretty convoluted sort of map here, but if you follow the little arrows through, it's pretty easy to follow. And again, it reduces the opportunity for error because it is a standardized process that keeps it very, very simple. And then these go up to our compliance officer for audit, and they ultimately go to the office of the medical director and any DEA notifications that may be required. So this is the checklist, again, for our supervisors. So they've got that protocol that I just showed you, but they've also got this checklist, and this checklist is included on all of our narcotic anomalies. So they have to complete this. They have to check every box. And if they don't check every box, they have to call me directly to explain why we're not able to check all of these boxes. So to give you sort of an example, here was one recent. So after the supervisor completes their investigation, they get all the statements from everybody. They send it to me, the logistics or the support services manager, and I complete an overall summary. So on this one here, it was a broken vial. So they came back and they were turning in their narcotics, and one of the vials was broken, or it was broken and missing some fluid. So we looked into it, we weighed it. We've got a jeweler scale here. We know that a full fentanyl vial contains this amount. This vial seemed to contain this amount. So from that, we're able to deduct that it has this amount of fentanyl. Both crew members go off for a drug screen. Everybody collects their statements, and that sort of summarizes the investigation. But it allows us to dig deep into it. It's not a superficial, I'll just wave it off. But these sort of things get caught when the culture dictates that narcotics are a big deal, and we're going to look into all of these. We're not going to brush these off, and management is very important to us. So That's sort of how the anomaly process works. We talked a little bit about the quality assurance. So the way we do that is we set up a spreadsheet that measures the usage of every employee's, or measures every employee's narcotic usage as well as the waste. And what it's looking for is, are there any outliers? So that is anybody administering or wasting more than 2 standard deviations of the general use of the organization? We used to do an average use, but what we found was with an average use, you miss out on your part-timers, or anybody that may be working a lot is going to be going to get a drug screen once a month. It's just not fair to those folks. So we normalized it for patient encounters and transitioned over to the bell curve model, where you're looking at your 2 standard deviations, because now that is going to be outside of your 95% of users. So that means you wasted a lot more, which is a red flag and something that should be captured, because we've had some diversions that occur that, the patient gets 25 mics and then I wasted the remainder 75. Well, the truth was the 75 was going to the paramedic and not getting wasted. And so the high wastage is a good indicator. And this is sort of what that looks like, right? So this is the total fentanyl use by medic. So you can see that the top 5 medics there are outside of those 2 standard deviations. So our average before was 312. And you can see just from this, we would have done drug screens and investigations on a lot more people, unnecessarily so, by sticking with the average. So by going to 2 standard deviations, we're looking at a much more statistically accurate number, but it also allows us to focus our efforts where they really should be, instead of just sticking with average numbers that may be skewed by call volume, or if somebody was off or happened to work more than others. This gives us a better picture into that. And then, like I talked about, the waste patterns are extremely important as well. So this was somebody that we captured or caught, basically diverting narcotics. And you can see the provider A here is the one that was the challenge. Waste numbers were right around average there for a while. And then January, February, March, they started going through the roof because they thought they were getting away with it. And turns out they didn't. But this was a great opportunity for us to capture. Their usage was fine, but the waste was through the roof. And so caught a diversion that way. So if the diversion, or if their usage or wastage is very high, it goes through not only the compliance review to make sure there's, attendance is good, their narcotic usage isn't extreme, but it also goes through a clinical review, and to ensure that it's being used correctly according to the clinical protocols. But also if there needs to be some discussion about critical decision-making or clinical decision-making, and so those go to face-to-face reviews with our medical director. And they may be correctly using it. They may just have run, last month was an ortho month for them, and they just ran a lot of fractures and breaks and falls and sprains. And so they were all clinically correct. They spend a couple of minutes with the doc. Doc says, yeah, no, you're doing a great job, looks good. They may not go for a drug screen, they may go for a drug screen, but it gives the medical director an opportunity to see sort of what's being used in the system, right? Because they have to sign for all these things, but also an opportunity to have these face-to-face engagements to see if maybe we need to change the protocols because this person went to a CE and they're treating pain more aggressively. Maybe we all need to do that. Or, this person's making poor decisions and they've had an unusually high number of intubations this month. And well, it turns out it's because the Versed use was so high. It captures both of those there. And then drug testing, we do 3 different ways as it relates to narcotics. So we do random drug screens of employees every month. That's any employee that has sort of hands-on contact with narcotics. So that includes all of our logistics techs, our paramedics, our EMTs, anybody that has access to narcotics, in addition to the normal drug testing policy that we have at MedStar. As well, we do reasonable suspicion. So this is your sort of, you're stumbling through work, your attendance is a challenge. There is some indicators that there may be some impairment, then we'll do a reasonable suspicion drug screen. And then finally, we do the narcotic anomaly drug screens. And like we talked earlier about, that's an anomaly is anything that's outside of the normal and established protocol. We'll do a drug screen to make sure there's no diversion that way. What we learned with fentanyl, though, is your test must be specific to capture fentanyl. So we were doing, the quick 8s and a lot of those opioid panels, expecting that would capture fentanyl. and found out, had a new medical director of our occupational health clinic come through and pointed out, hey, this does not capture fentanyl. It synthesizes differently in the body, and it doesn't come out like you're expecting it to. And so did some research and come to find out he was not off his rocker, that there was some truth to that. And so we do a test specific to fentanyl that has to actually be sent away to the lab to make sure we're capturing any use there. But very important that you sort of look at all the facts, right? So review all of your data, and you can only do that if you had good data. And that's what we learned early on, is that if we weren't capturing good data on the head there, then we weren't going to be able to manage diversions. We weren't going to be able to manage our narcotics very well. So that's where we've continued to evolve and learn ways to track better and stay on top of this. But don't be afraid to ask questions. Recently, we had a couple of our supervisors actually write out the protocol, the narcotic process from memory, just to see what is your picture of how this looks like, and is that in line with how the current protocol is? Unfortunately, they were all pretty spot on, so it didn't indicate any need to do additional training or to change our protocols, because that was the other thing we're looking at. If they found something that works better that we need to do, that is still compliant with all of our expectations and sort of the DEA regulations, then maybe we can make a change. But don't be afraid to dig into attendance, performance. All of those things matter, especially when you're looking for diversion. And make sure you interview all parties. We've had EMTs or secondary medics diverting. So I want to make sure we're capturing that. And then work with your medical director to make sure there's an adherence to protocol, because they may not be using, but there may be some clinical challenges that need to be addressed as well. Overall best practices, though, all these things we've talked about. Know your process as well, and work with the other departments in your system. Know your state and federal requirements, and build a good relationship with your local DEA agent. We've got a great relationship, thanks to our compliance officer, with our local DEA agent. So any questions, concerns, any thoughts even come up, we can reach out to, hey, are we doing this right, or should we be doing this differently, or what are your thoughts on this? And able to get that feedback so that we can stay in compliance and keep doing things the right way. Make sure you've got well-defined processes for all the things that you do. And as much as we want to expect that people have good hearts and we can always trust them, make sure you've got a good way to verify that information, especially as it pertains to the narcotics. I'll finish up with a quick little story here. We had on a diversion, we had one very clever guy that was diverting fentanyl. And what we learned is that, so what was happening was we were getting medics that were going out on the street with fentanyl vials, and they're reporting that the lids were harder than normal to get off, or the medication didn't seem to have any effect. What we found is that this medic that was diverting was popping off the lids, drawing out medication, and then actually supergluing the lids back on exactly as they had been found. Without our ability to track individual vial numbers, we wouldn't have been able to trace back to find a commonality in ownership of those vials, because what we did is we looked to see of these, vials that are affected, what is the one name that keeps coming up, and we're able to find one or two names through that vial tracking, and then identify who the user was and manage that effectively. But don't ever think you've seen everything. They will continue to evolve, so make sure your process does as well. And with that, I will open it up to questions.
Great. Thank you so much, Shaun. We'll now open the floor to attendee questions. So if you have not done so already, please use the question tab in your GoToWebinar panel, and we'll try to get as many of your questions answered as possible. So I have one to get started here, and the question is, any value in using biometric as the secondary method for accessing the system to reduce the opportunities related to shared passwords?
Yeah, so there's tremendous value in that. If you can use biometrics instead of password and PIN, that is just one more device to manage that more effectively. It's something we don't currently use. I struggled a little bit initially because we were trying to use the biometrics, and then folks had to also remember a password and PIN for their usage and wastage, and we were finding a lot of folks forgetting those numbers. So if you're forced to put that password and those numbers in on a daily basis, they tend to remember those better. But absolutely, if you can find a way to use that, that is a very effective tool.
Perfect. And then to kind of piggyback along with your answer on that, as far as the verification methods, biometric fingerprints is one of many verification methods that your crew can use in that single or dual verification, along with PIN password and also an on-screen digital signature. So biometric fingerprints can be one of those primary or secondary methods there as well.
Yeah.
The next question, on the daily, those grids that you showed for the daily audit and daily reconciliation screenshots that you said were a little complicated at first and they're pretty helpful now. Where does the data from those come from? And is that a report in Operative IQ? Do you get the data from Operative IQ? Explain that just a little bit.
Yeah, so it's a great question. So all of that data is captured in OIQ and then used to complete that form to then reconcile against the physical count. So what we've done is on the Narcotics tab or in the Narcotics reports of Operative IQ, you can create a dashboard. And in that dashboard, when we open that up, it populates on screen all of those values that we're looking for to complete that spreadsheet. So it's literally, I am transcribing numbers from this screen over to this Excel spreadsheet. And the reason we don't just export out an Excel spreadsheet from Operative IQ is that that spreadsheet that we use for reconciliation has all the math and everything built into it. So they use the dashboards to identify how many fentanyl are in the field, how many are supposed to be in the safe, how many are supposed to be at our North Deployment Center, fill those out. And then that last bar, that green bar, gives you the number that you should have in your safe. And that's, like I said, captured multiple times a day.
Perfect. And a quick question came in about this recording being available for later viewing. It absolutely will be emailed to you, so you'll have access to view or share this recording moving forward. The next question, Shaun, is where do you store your narcs on the ambulance?
So we store them in those Pelican 1010 pouches. We are moving away from one type of ambulance, moving to another. On our new builds that we've started getting for the last couple of years, we've installed Knox boxes, and they're Wi-Fi controlled Knox boxes with PIN numbers that give us the ability to track who's been in and out of the safe. But narcotics are able to be stored in that Knox box in the ambulance as long as it is staffed by a paramedic.
Great. And then the next question, how do you assure that crews, are not pencil whipping the opiate and not physically checking the narcs at shift change?
So because they are, and let's be frank, they absolutely can. They can say, yeah, everything looks great. Here's my password and pin, and I'm out of here, right? But there's accountability to that. So if something comes back missing, then we're able to go back and say, you check this in and out. You confirmed that these were intact, so it is your responsibility now that these things are correct. So we find that while I've got a couple of lazy folks out there that don't want to put the effort into it, the majority of folks will take the time to verify contents and vial numbers. But you're absolutely right. There is that opportunity there with any system that you use until you get burned, and then you are held responsible for the narcotics that you said were intact.
Sure, and that's what I would say. Where there's a will, there's a way. But that line before it's caught is a lot shorter than if you're doing it on paper or you don't have those double checks. Exactly.
And which is very, very helpful to have the vial by vial tracking, because now we're able to capture that, whereas before, sort of a hope and a wish.
Absolutely. And that leads into the next question. What's your frequency of keystroke errors? Oh, goodness, hold on. My screen just moved. Hold on one sec. There we go. What's your frequency of keystroke errors when vial control numbers are entered in ImageTrend or Operative IQ? Do you treat that as an anomaly?
So fortunately, it's very low because when the narcotics are assigned to a paramedic or to the crew, you're only given 4 fentanyl vials, and so you have to select from one of those. Now, what we find is in the patient care report in ImageTrend, they may put in error, or there may be an error in there. And that's why we use 2 repositories, because it's unlikely you'll make the same error in both databases. So before that pouch is checked back in at the end of shift, any usage is reconciled against the other database. And if we do find an error there, that's set aside the patient care report can be sent back to the crew member and amended. Or if they made an error in operative IQ, they can amend that report as well. The most common issue we have is if I've got, vial number 1234 and vial number 1243 in the same pouch, they may transcribe one of those, and that one's a really simple one. We don't treat it as an anomaly because they still have the vial intact, and the usage matches and everything. So that one's just relabeled.
So what do you do if the counts don't match up? How is that managed?
So it escalates through the investigative process. So normally the two offgoing folks, the ongoing, offgoing crew, will manage it. It's like I said, 99% of the time, it is somebody punched in a 2 instead of a 3 or punched a number into the wrong column. If they can't identify the issue there, excuse me, it goes up to the supervisor, and they've got a few more tools, some deeper audit capacity. They can look a little deeper and see if they can't find it. If they can't find it, which has only been two or three times in the past several years, then it escalates to me. And myself and the compliance officer will work together to identify, is this thing truly missing? Is there a technical error? What's really going on with this? We've had one issue where we just happened to be doing ROIQ just happened to be doing an update at the same time we were checking in some narcotic vials. And so one vial just was missing in the system, but we had it virtually present. So we actually had an extra fentanyl vial. But other times the vial, you find it tucked away in the safe, or we've never had one just completely go missing.
Okay, that's great. And then another question along the same vein is, when a narc is used, does the medic's partner have to sign as a witness in the chart and an operative IQ?
So another great question. They do have to sign in both. And again, we captured in 2 different databases to minimize or at least identify the opportunity for error. Because if we get, Bob Smith, the partner, to sign on the chart, and then we got, Susan, the nurse at the hospital, sign as a witness, that's a red flag that, hey, we're shopping for waste witnesses. So was this, did we just pencil with the waste witness here, or, what's going on with this? So we do require it in both databases.
Gotcha. And are there any legal issues with the random drug testing as opposed to suspicious behavior or incident?
So for random drug testing, we actually outsource that to mitigate that risk, because there could be a risk if we continue to hit, an individual or a protected class. And so we actually outsource that. It's pretty inexpensive. They have a list of all of our employees and randomly generate a list of, X number of employees to be tested on a monthly basis. The reasonable suspicion and the narcotic anomaly ones have less of that risk because you have a documented incident where there's an opportunity for diversion or loss. Gotcha.
And can a sole admin or person access all narcotics in the main safe without a witness?
Can they access it? They can access it. They can get into the safe, but since you're tracking the vials and from the time it shows up here to the time it is virtually destroyed, that vial would come up missing in those counts.
Gotcha. And process-wise, I guess, and for the person asking the question, please let me know if you need more detail. But I'm wondering if that means for a safe audit, can one person be the person to complete that transaction without having a second person sign off? If that's the way I understand the question, you would be able to determine what would be what would require single verification and what would require dual verification. Is that how you would understand that?
Yeah. So anytime a vial moves from one safe to another, or moves from a safe to a paramedic, it requires a username, a password, and a PIN. So anytime that vial moves anywhere from its location, there's documentation of who moved it and where it went. They can do audits on their own, but it's just counts. They don't have any way to manipulate the numbers.
Gotcha. All right. So then the next here, let's see, lots of questions, so we'll try to get through all of them. how do you feel about RFID that Operative IQ has for narcotics, and what would the benefits be?
So I love the idea of our RFID. We're actually trialing RFID for inventory. I don't think it's quite there for the volume of narcotics that we go through. We had it here, it was demonstrated, very effective technology. Love the idea behind having the wire that, when you pop the wire, it's that RFID tag shows is it administered. It greatly expedites the process, and it mitigates the typos or any of those things that you may have. However, with the volume of narcotics that we move every day, it would require us to have multiple safes, and we would burn through an astronomical number of the little film canisters that the narcotics go into. Love the concept, though. Great idea, and I think that will be the next evolution of this process if we can get the cost and the if you will, the sizing of it figured out.
Sure. And just to speak to that from the Operative IQ perspective, where RFID is really helpful is in that master safe audit to track exactly what's in there live and what's left that safe electronically. And once it's in the field, you could absolutely outfit your Knox vaults with RFID to continue to track those tags. But since most of the transactions are logged in by field personnel to track what they did or when they administered, it wouldn't necessarily streamline things in the field, but it's really helpful at the safe level. So hopefully that answers your question. The other question on RFID was, what is your experience with RFID? What is your experience with UCAPIT lockers to eliminate logistics techs from the process? That's a good question.
Yeah, excellent question. We've talked to Boundary. They offer the UCAPITs, and have talked to them about hosting those at several of the hospitals in our area to reduce the frequency of folks having to come back for resupply. Like I said, we're doing the RFID with some of our inventory and trialing that on the trucks. Unfortunately, with the narcotics, I'm not comfortable moving totally away from the human contact because that human contact is what captures a broken vial, a wiggly label, or wiggly lid. Some of those little things that technology doesn't have the capacity to recognize. And with the UCAPITs, that would be an offsite. We could use them here, but again, you take out that human interface that is able to capture some of those things that technology doesn't quite have the capacity to manage well.
Gotcha. The next question was, and I apologize, it was regarding empties. Let me see if I can find it really quick. Does MedStar require all empty vials to be returned to close the loop on usage? And if not, is disposal into a Sharps container the standard?
Yeah, so the vial, once used, goes into a Sharps container because there's the opportunity for some biohazard there if they drew out of the vial more than once. But the vial number is virtually saved in the Operative IQ pouch or in the field narcotic pouch, and then moved back into the window safe until it is moved into a destruction safe by our supervisors. So they don't have to bring back the vial, the empty vials. They just have to document its usage in the EPCR and Operative IQ.
Gotcha. Another question was, can you possibly provide the spreadsheets that you use and the other job aids so that they could see as far as where the formulas are built and such?
I can pull up the audit sheet. The only thing I can't share or be real open with is the formulas on the standard deviation and the normalization. We don't want to put obviously too much information that would allow somebody to circumvent some of those processes, but happy to share those spreadsheets, and I thought I had sent those to you. Did I just send you everything but those?
It may be. So we attached 4 documents, and I don't believe that the audit spreadsheet was on that. But what we can do for those in attendance is we can, once I get a copy of that from you, Shaun, I can send a quick email out to all attendees with that information. So thank you for sharing that. Cool. And let's see, any issues with that? All right, give me just a moment. Where do you waste the excess narcotics?
Now, is the question regarding the paramedic has administered 2.5 of Versed and they're wasting the remainder?
That's what I believe the question to be.
You think so? Okay. For that they're wasted into a sharps container in the field. Now, if ever there's an anomaly or an expired medication, those have to be eliminated with the reverse 222. But as far as in the field use, it's wasted into some repository that protects it from outside use, and somebody can't get into it and, I don't know, try and sip it out of there.
Gotcha. All right. And I'm so excited that we've got so many folks jumping in here. I represent an EMS organization with much smaller run volume and narcotic use. We administer narcs maybe a handful of times per month. I have 1 or 2 medics on duty at any time, each carrying 2 fentanyl and 2 Versed. I'm the only person with access to our stock, narc safe. All medics have free access to the room where the field drug boxes are stored. We currently use all paper tracking, though I would like to move a lot of our operation to narc-related and otherwise an electronic model. Do you think your model's designed for a much higher volume system on scale that will scale down to a much smaller system?
Definitely so. I think there's components of it that wouldn't work well in that scenario. If you're able to get an electronic repository, that would just save you a ton of headache instead of you having to come up and physically manage those things. Realistically, your medics could, there's an option in OIQ to pick up from safe, and then they can transfer narcotics from one person to the next and then document their usage in that system. And I'm sorry, I'm not familiar with pricing and sort of what it would be on a small scale like that, but a lot of our protocols and processes are built around the individual vial. So they could easily be translated to a smaller system. And having gone through this process, if I could encourage you to do one thing, it would be to get it on an online platform where you can real time see where your medications are at, but also have the opportunity to see where those medications have been, when expirations are coming up. Run an easy Excel spreadsheet to see, is Medic 1 using the heck out of these things and Medic 2, 3, and 4 never do. But certainly scalable. If you can get it into, it doesn't have to be OIQ, there may be something else out there, but if you can get it online, man, it's going to save you a lot of hassle.
Yeah, I would agree. And from the operative IQ perspective, there are lesser ways to track your controlled substances where you can still do most of this electronically, even through our inventory module where you can still track expiration, lot, and batch. You can still load your drug boxes and still do audits throughout the shift and track when things were administered. Bringing things into the narcotics tracking module would allow you to track every single transaction. So total chain of custody from when you received it in, everyone that's ever touched it, all the way through final disposition. And that final disposition does bring us to another question, which was regarding reverse distribution. Do you have a process, a reverse supply chain, returning all used vials to your logistics, including the testing of contents to ensure that the expected contents are in fact there?
So we don't test the contents. That came up, I shared the story with you with the super glued lids. That came up for that. So we did test the contents on those ones to confirm what our suspicion was. But as far as the reverse 222 process, they are pulled from the system, whether it's an anomaly, expiration, or whatever, and they go back to one of our local pharmacies for destruction. I don't think that's included in those SOPs that I shared.
Okay, gotcha. And do managers have formal documented training in recognition of reasonable suspicion, characteristics, signs, or symptoms?
Yeah, so on an annual basis, our human resources department does a great job, and it's included in sort of that bulk leadership training, right? So you got to do all the how to talk nice to folks and the diversity training and the HIPAA training. And anyhow, in that is recognition. It's got a catchy name to it. I couldn't tell you what it is off the top of my head, but in there is reasonable suspicion drug testing to make sure you have some documented behavior or something that really gives you the authority to do that, so you don't get in trouble with OSHA or any of the other folks looking at that.
Gotcha. If you have a sprint truck with one medic that gives a narcotic, who signs as the witness once a unit is done transporting?
Great question. So that would apply to our supervisors and some of our critical care paramedics. They're in Tahoes, the fly cars. It would be unusual for them to be administering medication without somebody else there because they don't have transport capacity. So what we expect from those folks is if a paramedic or one of my supervisors, it rolls up on a scene that somebody is actively having a seizure and they administer half of their Versed. The expectation is they've drawn up all of the Versed into a vial. They've given half of it, or into a syringe and given half of it, or they've left half of it in the syringe or in the vial. And that way, when the transport paramedic arrives, they can witness and see the destruction of the remainder of that narcotic.
Gotcha. And really, a witness of that transaction could be anyone that you deem. Doesn't have to be a known crew member or a partner or even a medic within your organization. If you decide it needs to be the ER nurse or attending physician or even a partner agency on scene, you can kind of make those decisions as you build your system as well.
Yeah, that's a great point, because sorry, go ahead. I was going to say that's a great point. That's something we use with our Clipper van on some of our critical care transports with maybe a nurse that rides. So you're right.
Yeah, kind of like you would on. So what you're doing is you're replacing the paper process, but you're doing it just a lot more securely.
Right.
And then do you refrigerate the medicine on trucks? And if so, do your tags hold up to the moisture from the refrigerator?
They do. We refrigerate the Sucks, Rock, Dipper van. That's it. Just those three. And they hold up well. Actually, on the Dipper van, the vial is too big to make the little flag where you loop it around and stick to itself to prevent it from peeling off. So we actually stick it to the side of the vial, and we have never, knock on wood, I'm sure one's peeling off right now, but we've never had one peel off or disappear. So that's been good. And if it did, the nice thing is that vial is checked out to that person. So as it's coming back in, we're able to capture that, hey, we're missing this sticker, and able to replace that.
Perfect. And what is your opinion of one common drug bag or box, all medications, narcotics and non-narcotics, which has one numbered inventory control seal? Let's see if I understand that correctly. The narcotic contents of each box and documented by me using lot numbers when each box is stocked. I'm not sure that I understand that one. Is that one clear to you?
It sounds like the question is maybe around if I seal the box instead of individually labeling vials.
I think you may be right. I'm the one who stocks the boxes from the safe. Upside for us is we have all meds in one place, organized in a way we like. Downside is that accessing the box for any reason constitutes accessing narcs, and it must be documented as such.
Yeah. So that's a great way to capture those transactions in and out, but it doesn't quite give you the capacity to manage individual vials. And that's what gave us the comfort to know that if I'm having diversion or, the little super gluing lids on example, because in that scenario, I could open these narcotics, I'm checking them, right? But I'm checking them by myself. I decide to draw out the contents of a couple and then glue the lid back on. Or I've seen folks sneak a needle in underneath. It's unbelievable the way folks will work to get around some of those things. But if I start, losing medication that way, the only way I have to track that is that this group of medications went out, but I don't know how long that vial has been there, who touched that vial, or some of those things. So that's great. You are at least tracking that. So I commend you for that. If you could track it a little deeper, that'll give you better transparency and be better for you.
Yeah, and to your point, that's a great start. It will definitely get the process rolling. And then when you're able to take it to the next level, it just gives you a little more protection for your providers and your organization. Just a couple quick questions on the waste. We've had a couple other questions that are coming in about the disposal that are available for disposing narcotics and deactivating the substance. I just wanted to clarify that when it comes to your options for substances, they can either be administered in the field and the waste can be auto-calculated, and that particular vial can then be at its end of life and removed effectively from the active narcs in the system, still trackable, complete, chain of custody, entire life is still trackable, but it's no longer showing electronically in the box. Or the way Shaun's doing it is those empties can be returned, and they return it at the check-in checkout, so that those next steps for reverse distribution can be taken on that empty bottle or empty vial. So the question here was,
clear,
have you looked at...
You're not physically... Sorry, go ahead.
No, go ahead, Shaun.
I was saying, and to be clear, you're not physically turning in an empty vial. It's virtually in the narcotic pouch and virtually checked back into the window, which I know sounds bananas, but it's just a fail-safe for us to capture that, hey, there should be some utilization, or there should be some usage here. Where's that at? It's just one more step for us to make sure we're capturing all of those things.
Yeah, and to your point, it's an option that you can turn on or turn off, whether you would like those quote-unquote empties virtually to be coming back for that double-check process. Right. Shaun, there's a question here asking if you can show the slide that shows your image trend print report. Would you mind switching back to that slide real quick? And I'll answer a couple other questions here that came in. Where do you purchase the tags? So unless I'm mistaken, most of the tags that you showed were purchased directly from Operative IQ, and those tags are printable on a Zebra printer, so that as you receive or create those control numbers, you can easily print or reprint or retag any of those files as needed. So we've got the slide that was requested back on the screen so that you guys can see it really quick. The other question here was, many ERs in my area are not permitting their RN staff to witness narc wastage for fear of diversion liability, which makes sense. We run medic basic crews. Is there any legal or other issues with an EMT witness as opposed to a nurse or higher level as the standard?
So I don't want to offer any legal advice, but in our system, the EMT frequently is the waste witness because of exactly what you've said. Some folks don't feel comfortable. They don't know what you have in that syringe. They have been dealing with it for the last 2 minutes, and heaven knows what you put in there. So for a lot of our folks, they will use the EMT as the waste witness. It's just nice to have somebody off of the truck that you can't steal their password from or any of those things, to say, yes, I did indeed saw this person waste this medication.
Absolutely. So there are just a handful of other questions, but what I'm going to do, Shaun, if it's okay with you, is get these over to you so that we can get responses back to people, because I do want to honor everyone's time. And if you'll scooch back over to that last slide, we'll wrap up and thank everyone for their time today, because it has been awesome having you join us and share all of your information. So if you'll go to the next slide, go ahead.
Oh, not this one. This one.
No, one more back. You got it. So should you like to join us for more webinars like this, for awesome experts like Shaun that are sharing all the goodies that they've learned along the way, you can navigate to our website and click on the plugin tab and select webinars to register for upcoming webinars or even see past sessions. So if you'll go to the next one, Shaun, Operative IQ is invested in our clients' success, and these on this screen here are the folks that would be happy to help you discuss your needs, provide you with more information. You can schedule time directly with these regional account managers from our contact page. And again, we're just so fortunate to have some incredible expert users willing to share their stories. And learning from our peers is just so valuable. And this Client Success webinar series is produced with the intention of building and growing this community of users who can, reach out, help each other, not have to reinvent the wheel, and make each other better. So thank you again to our presenter, Shaun Curtis, for sharing his time and expertise with MedStar Mobile Healthcare. And thank you to our attendees for joining us today. We hope you have a wonderful day.
Thanks so much.
Bye-bye.